So what happens when I call the ED and I say, hey, this is, so and so squad. I have this patient. I suspect it's a sepsis. So I'm going to call the sepsis alert. What's happening differently on your end?
John, you want to let us know?
So just like our other time critical stuff, where we know that this patient's going to need a room, if you guys are calling sepsis alert, because we need to establish IV access, we need to establish get likely blood cultures from them. They're going to need fluid resuscitated. Goal for us is going to be 30 mLs per kg of idealized body weight. And we even account for what you guys gave in the field. So if you were running a liter in, I'm going to say, oh, they're getting a liter from you. They're 100 kilos. I'm going to give them 3 liters total. I'm going to put that order in. We can have discussions, and probably not here's the right time for whether that's normal saline or LR. There are studies out there to show LR superior to NS, but I still do probably my first resuscitation with normal saline because it's just quick and easy. It's always there, and what you guys run on the squads as well. we're gonna actually activate a sepsis alert inside the hospital as well. It kind of notifies a bunch of people like, yeah, we're gonna get radiology bedside sooner rather than later. Get that chest X-ray. We're gonna want to collect those blood cultures, and pharmacy is gonna be ready to both approve and maybe mix up some of our antibiotics of choice. And then the antibiotic of choice is gonna be based upon what their personal history is, what type of infection we're treating.
But your cultures aren't instant either, right?
They're not. Cultures are going to take absolutely at minimum. The quickest I've seen a culture come back is 24 hours, and at that point, all you're going to get is a broad classification
This
of
is
what
what's
that
growing.
is.
Yeah.
Yeah, it's cock size in pairs or cock size in clusters. That's all we're going to get at 24 hours. It will. Let's say they're gram-positive cock size in clusters. That's staph until proven otherwise, and we're going to assume it's MRSA, and we're going to treat you for MRSA. But we're also going to do a NAIR swab for you to see if are you a carrier of MRSA, and because if you are, we're going to keep on our MRSA antibiotics longer. If you're not, less likely to have a MRSA infection, or have no history of MRSA infection, we're going to probably de-escalate those off of the MRSA drugs because we don't want to. We have to then talk about antibiotic stewardship and what are we going to select to treat that best. I guarantee all 4 of us here are, if we swab for MRSA, we're going to screen positive for MRSA, just by fact we work in healthcare, right? I've personally had MRSA infections. I've been on vancomycin for, unfortunately, weeks at this point. So just because I developed a MRSA infection in the hospital. But I guarantee all of us have MRSA.
It's something to mention, though, that if you tested positive for sepsis, that throwing the heaviest antibiotic at you all at once is not the best goal there, because if something easier might have fixed that or killed the infection, it's a lot easier on your system. Not just to mention going forward, if you have another issue, you've pretty much wiped out your immune system already now.
So a few things different. And most of our strong antibiotics, we'll pick on vancomycin, one of our go-to drugs for MRSA infections, can be very hard on the kidneys and probably causes a lot of kidney injury associated in the hospital system, especially if we're talking about patients that are if they're going to be hypovolemic from their sepsis because they need fluid resuscitated, the kidneys are probably under injury anyways, and now we're adding a kidney toxic medication on top of it. We're probably going to injure the kidneys more.
Yeah.
On top of all the other things we throw at them, whether that's different medications, drugs, just not giving the kidneys enough fluid that they need, and then the controversy of whether iodized contrast for these patients is nephrotoxic as well. So we insult the kidneys a lot during most hospital stays, but definitely during sepsis. And then there's other medications that can be both liver toxic, and some of the other ones we talk about and learn about in med school is ototoxic, so medications that actually can damage hearing. Bigger concern for the pediatric population that some of the medications we give can actually cause hearing damage. There are some medications that are going to cause bone damage to you if we give it to you too young, if your bones aren't developed enough. So it's a big matrix of things we have to consider when we're trying to manage those patients from an antibiotic standpoint. But then I want to give you, and just like in whether you're seeing your primary care doctor, right? We want to give you the lowest amount of medication that's going to treat whatever
help the body heal itself.
Correct, and that's
kind of what we were talking about off camera. Even it's just like, it's even with ECMO and all that. I mean, it helped the body take a break, time out, so it heals itself. How reliant or good of a tool is a shock index to use? I mean, you're doing heart rate divided by the systolic blood pressure, If I get something, above 0.9, I'm going to want to give them fluid.
It's a reliable indicator, and once a patient develops septic shock, classically identified as failure to improve the blood pressure in a hypotensive patient after a fluid bolus is given, you know that you're on a slippery slope with that patient. The patient's already starting to go on a downward spiral. Mortality is very high with septic shock, so what you've got is a patient that's got a tremendous amount of inflammatory stuff going on within the body that's causing that intense vasodilation, causing serious vascular leaks, and also interrupting perfusion. Incidentally, going back to what Ray had mentioned with carbon dioxide assessment in these patients, that's very important because remember, if you perfuse your cell well with glucose and oxygen, carbon dioxide is a natural byproduct. So if you don't perfuse your cell well, because of a shock situation, regardless of the type of shock, and today we're talking septic shock, you're going to have decreased production of CO2.
Under 32?
So CO2 production is an index of perfusion. A lot of paramedics need to be reminded about that. They only think of CO2 in relation to respiratory-related, COPD-related issues. But and I can prove it because if you have a patient, for example, with cardiac arrest and you're doing CPR even under the best of circumstances with a Lucas device,
You're gonna get
what are the
something.
CO2 levels in that kind of patient?
Sure.
If you're lucky, if they're 10 or 12,
10,
right?
12, yeah.
And then sometimes if you get ROSC, what's one of the first indicators?
jumps.
Yeah,
the
it jumps
CO2
up.
level goes back up, even oftentimes before you can get a pulse or a blood pressure. So CO2 monitoring is very important, and that's why you had mentioned capnography
Yeah.
as one of the tools that we can use pre-hospital to help assess the patient who you suspect may be in either sepsis or going into septic shock.
I always look at that as like a live feed, right, of
Yeah,
how the patient's
absolutely.
doing, right? So since that is a byproduct of metabolism, that's going to show you how well their body is performing or handling that infection or how poorly they are. So, like we always compare SpO2 to end tidal. And you look at it as like SpO2 is just extremely delayed, could be inaccurate because your hands are cold or you have LED lights in the back of your ambulance, et cetera, et cetera. Whereas if you're getting a good end tidal reading and you have, a good respiratory rate, which these patients early on are going to be tachypnic, so you should, it's going to give you probably a pretty decent accurate respiratory rate, but it's also going to give you how well is the byproduct of their metabolism really working to show you how sick are they, right? And it's a live feed, it's instantaneous. So you're talking about distributive shock and how we would use normal saline to try to bolus to try to fix distributive shock, because we need
Potentially
to put
push dose epi.
yeah, and then if that's
bad enough.
unsuccessful, then we're going to get to push dose epinephrine, which is our treatment, and we've even expanded on. I don't want to call it our loading dose, but our initial push of up to 50 mics to try to get some reception on that, but very easy to make, and from an EMS standpoint, I think we start the IV, I'm with you, I'm pro LR, but give the fluid bolus while my partner's probably making the push dose epi, so I'm going to try to do a bolus, see if they respond to the bolus, but I'm preparing for the worst I'll have my push dose epi ready if needed. So, the other paramedic that's with me can prepare that. So if my fluid bolus is unsuccessful, then I'll transition to my push dose epi.
Absolutely. And epinephrine is the most versatile drug in the drug box of the paramedic. It is used for so many purposes. And the beauty about epinephrine in the setting of septic shock, once fluid bolus has failed, is epinephrine is not only good for beta-1 stimulation. Remember, the heart has beta-1 receptors, one heart beta-1, and when you stimulate those beta-1 receptors with epinephrine, you have increased heart rate, you have increased contractility or force of contraction. Those are two methods by which the body compensates for the shock situation. But the third and single most important compensatory mechanism is vasoconstriction. And epinephrine does also allow for vasoconstriction because of activation of the alpha-1 receptors in the blood vessels. So epinephrine is a great drug.
Especially for distributive shock, because
Exactly.
we have a problem with the pipes. So the way I always explain distributive shock when I teach it is, because like anaphylaxis is another form of distributive shock, right? So I always say, the easier way to say it is like you get stung by the bee and you have a gallon of milk in a gallon container. So after you start to have your anaphylactic reaction, I pour the gallon of milk, which is your blood volume, into a 5-gallon bucket now. You didn't lose any blood, but now your container has changed.
Without
so
anything to squeeze.
your pipes have dilated to the point of, you don't have a blood pressure, so you're in anaphylactic shock. The same thing with sepsis is you have massive vasodilation.
Here's an
that's
analogy
where
I
epi
like to
helps.
use in class with vasoconstriction. I say, imagine this water bottle is full. Imagine I punch a hole in the cap of that water bottle and I gently vasoconstrict that. That water is going to shoot out with a lot of force,
Yep.
and I could hit people in the back of the room. So I kind of use that as a metaphor for vasoconstriction, which is a very effective compensation mechanism. And epinephrine in the field is great because it does all three. It increases heart rate, contractility, and causes vasoconstriction.
And we do the same thing in the hospital too. If our fluid boluses aren't working, we're going to jump to vasopressors, right?
Yeah.
We have a different choice in vasopressor as our first line, but I still use epi at bedside if I've got a crappy blood pressure. I still mix up push dose epi, and we give that as I'm getting Levophed up from the pharmacy. And then if we're going that route, we can still run it peripherally, but they're so quickly moving to a central line, so I got to prep for that as well. So it becomes a very highly sick, critically ill patient that takes a lot of our attention, a lot of time. We talk about time to antibiotics and, again, time-sensitive medicines. Current standards are 3 hours from the identification of sepsis to getting antibiotics in. That's a long time. The newer studies are looking at and trying to get us down to sub 1 hour of getting those antibiotics as soon as possible.
Where you may need EMS's help in that then.
Yeah. Fluid resuscitation is going to be the most important non-antibiotic intervention that we're going to do. So we're going to fluid resuscitate, and we want to get those antibiotics on board as soon as possible. And to that point, like, you're going to have really high mortality rates, better than 50% in these septic shock patients.
Talking about mortality rates, I thought that was interesting. I took these notes that, 65 to 74 years old, 15% mortality rate. Now look at the jump.
That's all
75
comers, right?
to 84. Yeah. 75 to 84%. You're now at 38.7. And up 85 and up, you're at 75%.
Yep.
Like, to me, that's just an amazing jump progression there. That's
And don't discount the importance of getting those fluids on board early. So in the field, a lot of times, paramedics say, I couldn't get the IV. And they don't even think about IO.
we have the IOs, yeah.
And I tell you, I've had several patients where I've worked in Conneaut where the decision was made not to try an IO, and it was very detrimental to the
Is that
patient.
out of fear or?
I think it's out of inexperience. This one particular squad came in, and they said, okay, we'll try an IO, doc. It was a patient in VTAC who was stable, and they were going to get amiodarone. They used the little blue needle in a patient that had a bit more shoulders than I do,
That's
and
not gonna work.
all of the amiodarone infiltrated into the soft
Sure.
tissue. And so, after talking to the medics, they haven't had any training really on it recently. They haven't done enough of them to be good at it, and they forgot the technique. So I think it's helpful for squads to be reminded on the proper use
Well, I think
of the
something
yellow
that
needle
didn't
for
help,
humeral.
Yeah, something that didn't help was, I think, in our protocol for the longest time, it was tubular tuberostomy. Like, you put it in the leg, and then all of a sudden we changed to that upper arm humoral, and everybody I've talked to that hasn't done one is like, oh, I go over the leg because that's what I'm used to. But as soon as they've done one humoral head, it's like, oh, that was nothing, and the next thing you know, they're doing them on everybody. And it's like, get over that. And if you need help getting over that, we have the mannequins here that we can go train. We can.
Well, and
Get those fluids on board.
Yeah.
It's really simple to do the humoral head IO. Like, if you,
I think
just
more
with
so
the way,
than the leg.
just with the way John's sitting here, I know this is hard, but if we find the space,
Show us that shoulder, John.
I find the center of his shoulder, my two thumbs come together. Usually that's going to be about
It's
right
there.
where the
It's-
seam of your shirt is, and you put your thumbs together. You should be able to push up and start to feel like the head of a golf tee.
Yep.
There, 45-degree
And
angle.
an amazing thing is in the
Like-
trainings they tell you, put your arms up at this angle or on your belly button, right?
Yeah, you can turn your
Where
arm
do we
in
strap
to
them on
move
the
the
Lucas
muscles.
machine? They're pretty much right where you want them.
Yeah.
Well, and the other thing too, the humeral head IO is superior to the tibial IO when it comes to fluid resuscitation. I want to say the last
absolutely,
numbers
yeah.
were like, it was 1 to 2 or 2 3 to. It was 1 to 2 liters or 2 to 3 liters an hour in the tibia, where you're looking at like 5 to 6
Right.
liters an hour in the head of the humerus. So it's like, why would you not want the
Yellow
superior
needle.
fluid administration?
Yellow needle.
But yeah,
And
it's
you
the yellow
don't-
needle.
You don't have to bury it either. I mean, just if they are small, you're still using it, but you don't have to bury it. Like, just there's
Well-
actually directions on the needle as how to use it.
And to pull in some AHA stuff, right? AHA update just happened. We're recording this in November of 2025. AHA update came in October. and it's still pointing to IV is greater than IO. Yeah, if you can get an IV, that is still
Great.
awesome. That is our preferred method of delivery. But if we can't,
Yeah.
and then these patients that are truly very sick, very hypotensive, they might not have enough blood pressure or blood volume to expand up to get an IV. You might need to start your resuscitation with an IO, and then what's the first thing that happens in the ER? We're going to take them off your cot, and we're looking for IVs. Whether they're in cardiac arrest or they're super sick, we're still trying to get that IV because it's still the better access over IO.
I think that goes back even to the point we were talking about earlier at lunch, that like some of the respiratory staff had mentioned that we're not doing enough advanced airways, and it's like, well, we don't want to. We don't want to give somebody an ET tube or put them in pneumonia for the rest of their stay. We would prefer to do less invasive procedures until we have to, and it goes the same with IVs. I mean, I'd rather do an angio, IV angiocath than putting somebody with an IO. So,
well, back to your point too. Like, we have a dialysis center in our coverage area, so if they're really sick, we train our people to go there with the mentality of like, if you can't get an IO or if you can't get an IV and they're really sick, transition to IO like sooner than later, because
and some of the dialysis
you need the access.
May, to your point, may be full of it might be not a good
fistulas
site
and shunts, and it's just your accessibility goes down. But you know what? For the most part, your humoral head is
it's usually
readily
there.
accessible. So if you have to have it, and those patients are prone to infections because of their ports being accessed so frequently, and it's just a warm, fuzzy environment for an infection to start. So.
Absolutely.
So we talked about aggressive.
We
talked about aggressive fluid resuscitation and its importance. How in EMS we could switch to push dose epi if needed, and how antibiotics aren't a one size fits all approach depending on the type of infection. We talked about lactic, and then unfortunately, we're not all there yet with a point of care testing meter, which would be awesome.
Well, and
We're just
lactic
not there
to
yet.
me is a sign of hypoperfusion.
Sure.
It's I can't rely on they've got a high lactic. Well, that doesn't mean they have an infection. Just because they have a high white blood cell count doesn't mean they have an infection. Just because they have a fever doesn't mean they have an infection or a bacterial infection. So, I mean, you can't take everything just by itself.
You have to put the whole picture together.
It's a whole picture thing. And I think the better thing to do, especially from an EMS standpoint, and it took me a minute to learn this as a doc, is has this happened before? Oh, yeah, it happened like 2 months ago.
What was it?
What was it? Oh, they had a UTI.
Yeah.
I think I know what's going on here.
I think something else too that you generally look for that hot, warm, flushed skin,
Sure.
and not cold, clammy. And it's like there's kind of a differential there too. That if you walk in as an EMS provider that's been doing this longer than a couple of years, you can look at somebody and say they're septic. 9 times out of 10, you're going to be right once you put your hands on the patient. But that's without putting my hands on the patient, I don't know anything about them.
I think that's one of the things that another one of my pet peeves is not touching your patient.
Yeah.
If you have kids, which you have kids, don't you? I can touch my kid and I know they've got a fever. It's made me a better doctor. I can touch my patient and go, yeah, you got a fever. And I ask nursing, hey, what's her temperature? Oh, it's 97.7. I'm like, check an oral. Why? Did you touch your patient? Because they're burning up. They've got a fever. Oh, how'd you know? I touched my patient.
Yeah, my kid wants the cuddle. It's like, oh, she's sick, Cassie. I know she's sick.
Yeah. I can't tell you how many times when I review charts, I see paramedics assess patients with abdominal pain and fever,
Without
and there's no abdominal examination on the chart. It's like, that drives me crazy. How can you not put hands on a patient? And that goes back to, when I said the basics are sometimes the most important things when it comes to sepsis recognition. You have to take a good history, utilize risk factors in your assessment. I think paramedics should be risk factor experts. They should know the risk factors for PE. They should know the risk factors for coronary syndrome. They should know the risk factors for sepsis. And then do the full physical exam looking for the potential source of the infection, whether it might be the skin, the joints, the urinary tract, or some infected device indwelling in the patient. So all that's important. So I think paramedics could be doing a better job with some of the aspects of physical exam, including that abdominal exam, because a lot of times the abdomen will hide that source of sepsis when nothing else is evident.
Who's the patient that's septic that we're just behind the 8 ball on? How quickly do we need to act, and how quickly can sepsis show its face?
Well, septic shock is relentless and very lethal once it gets to that point. And of course, sepsis can progress into septic shock if we delay the treatment and don't intervene, like John said, with the fluids, the oxygen, the resuscitation that starts immediately. And again, the more susceptible the patient is because of their risk factors like diabetes, or if they're on Humira or some other kind of immunosuppressant. Cancer patients are also notorious for being susceptible. These folks can go downhill relatively quickly. And that's why we call it a time-sensitive condition, just like STEMI, just like stroke. We know that patients with STEMIs are potential time bombs because any number of complications can be occurring while you're monitoring the patient en route. They could go into cardiogenic shock, they can get VFib, they can have pulmonary edema immediately, they can get bradyarrhythmic, tachyarrhythmic. Any of those things can happen within the blink of an eye. Well, same thing with the septic patient. You've got to have that mindset that these folks can go downhill quickly. Sepsis is an aggressive deterioration waiting to happen, and once they do deteriorate, it's hard to to stop it. So that's what I mean by that sepsis mindset. We have to be looking at it like the STEMI of infectious disease.
Mm-hmm.
I have one
Septic
patient
shock.
that comes to mind about like how quickly it could deteriorate. We had a call like 3 a.m, and it was at a facility, and it's wintertime. The patient's just in like essentially a diaper, no blankets, no nothing, unresponsive, breathing 36 times a minute. And I literally was like, this guy's got to be septic. Like, I didn't even need any more of the story. I was like, he has to be septic. And then, like, didn't have a fever, but we were going the other way where he was cold. And I was like, oh, this is really bad. Like, cot, ambulance, IV, start a fluid bolus, mix up epi push dose, start going, cardiac arrest. I was just like, end tidal was like bottomed out.
It's
It was like
almost
20.
rapid
Like,
at
it
that
was
point.
it was so fast. And it's not like we didn't recognize it. We didn't try to do what we could do. I mean, we started our fluid bolus immediately. We immediately tried to mix and go to epi push dose. And literally as we were going to epi push dose, the patient went in cardiac arrest like immediately. But that was, missed by the facility, recognized by us fast, but
You guys just didn't have enough time with the patient.
correct. Yeah, we
Intervene,
didn't have enough time to try to fix it. We recognized it, but I was just like,
Yeah.
this is crazy how fast we went. Like, we knew what we were doing, and I thought we had a great path forward. I was like, all right, well, we acted quickly, and no, I mean, it was
Sepsis
it was like we didn't have a chance. Like,
is notorious for causing end organ damage, and multi-organ damage, of course, it happens with septic shock. So the brain becomes the target, the heart becomes the target to reduce cardiac output, the kidneys become dysfunctional, the gut becomes dysfunctional, the lungs become dysfunctional. So all those dysfunctions are the reason why patients deteriorate. One of the reasons why patients become hypothermic instead of hyperthermic with sepsis is because you have hypothalamic dysfunction. So it's the hypothalamus, which is the temperature regulating center, is also dysfunctional. So sepsis will knock out every organ if given a chance.
and that's why it's kind of so deadly and so bad. Is it's multi-system, right? It's multi-system dysfunction that. It's not like it's a STEMI, it's a heart attack, it's only affecting the heart. It's not a stroke, it's only affecting the brain. Now, granted, those are both important, right? You need your brain to function, to do your activities of daily living. You need your heart to pump blood. But if I'm affecting all of those important systems at once, sepsis can actually be terrible and is very deadly. But you touch on a very important part that I didn't get a chance in the last podcast record about to have me step on my soapbox about medications, right? You need to understand what medications they're on, because if they're on a medication that's modifying their ability to fight an infection, whether that's Humira, they're on some type of antibiologic medication, they're on long-term steroids. These medications are going to reduce their ability to fight an infection. Maybe they're on a beta blocker. How many patients over the age of 65 are on metoprolol?
A lot.
The vast majority of them. They may not
They
be able
can't
to
compensate.
Nope.
they can't compensate, or nor can they even mount a tachycardia. They can't mount. Maybe the fastest their heart rate can get up is 85, and they're never going to get above 90. You, as the provider, basic, paramedic, physician, APP, needs to be like, this doesn't make sense. They should be tachycardic. Their blood pressure is low. They should have a higher heart rate. Oh, they're on a beta blocker. They're unable to mount this tachycardia.
Yeah.
as a response because of the medications we're giving them. So being aware of what medications that they're on is going to definitely help you guide
That's a good
how you
point.
manage those patients.
Phenomenal point, because I mean, we're not just speaking to the paramedic and advanced EMTs out there. This is also basics. So
Yeah.
what is a basic doing in the back of an ambulance for a septic patient?
If they're hypoxic, you're giving them oxygen, right? You can, if appropriate, you can give them essentially a 500 cc bolus of fluids by laying them flat and putting their feet up.
Yeah.
If they're hypotensive and that's all you can do, take a perfect example in recent news, right? There was a press conference in the White House, and in the Oval Office, someone collapsed. They put him down to the ground, and there's pictures of their feet up because he collapsed. And now you're essentially bolusing those
You're shoving
fluid
them.
in the legs. You're shunting it back to the body. That's a basic procedure. They didn't have any IV access.
Did you know our
there.
cots can do that?
I wonder why. I wonder if there's a reason for that.